So, good evening, all the aspirants present here. This is the EDIC Part 1 crash course where we'll be going to start GI, and the speaker that we have here is Dr. Asif sir.
Yeah, thank you, Sana, for your kind introduction. So, in the gastroenterology student, I will tell you the three area is very important. You will definitely get question from this three area. One is your acute renal failure. Second is your upper GI bleeding, and yeah, the 60% question for and the pancreatitis. This three will give you the 80% question, and the few question you will get from the CLD chronic renal failure and Tania, আমি অফিসে চলে এসেছি and you call me after 8:30. I'm in a class right now. So thing is that there are 80% question you will get from this three area, and the remaining 20% question you will get from the chronic renal failure, chronic liver failure, CLD, and where CLD there are two important area. One is the spontaneous peritonitis, bacterial peritonitis, and you will get the hepatorenal syndrome. Hepatorenal syndrome is very common and very popular area for EDIC 1 exam. You will get the question from the hepatorenal syndrome. If you follow my lecture in upper GI bleed, then you will see that I have covered all this area where the question come from. Now let's start today's. My main focus in this three area, because you will get the maximum question from here. So the first question is and remember this exam you have a 60 or 65% question you will get type A, and 35% question you will get type K. Type K is the true and false answer, but the marking is like that. If you done three option right, you will get half marks, and if you get five option right, you will get full marks, and below that you will get 0 marks. But type K question actually check your depth of knowledge. Okay. So in the GI, you will get a lot of type K question from acute liver failure and also from the pancreatitis. Now, coming to the acute liver failure, N-acetylcysteine NAC is beneficial in non-paracetamol induced ALF. You can write down your answer in the chat box. It will be helpful for discussion. Intracranial pressure monitoring is advised in low-grade encephalopathy. Acute liver failure is characterized by low cardiac output and often require vasopressor support. And high positive end expiratory pressure may exacerbate hepatic congestion. And hepatocyte necrosis cause hyperglycemia. Now, please give your answer in the chat box. Yeah. So let's see. So N-acetylcysteine is beneficial in so Shrikant Koti has given this is a K-type question, so you have to answer true false manner. So first one true, then intracranial pressure monitoring is advisable for a low grade encephalopathy. No is yes, right answer. ALF is characterized by low cardiac output, often require vasopressor support. Yes. High positive end expiratory pressure may exacerbate hepatic congestion. Yes. hepatic necrosis cause hyperglycemia? No, it is false. Now let's see what is the answer given here. Then we will go for deeper discussion. So N-acetylcysteine is both effective for paracetamol-induced acute liver failure, and also the evidence says that NAC is maybe it's a good effect on the non-paracetamol poisoning. Intracranial pressure monitoring, it is not mandatory, and definitely for the low grade encephalopathy, no. In a high grade where the brain edema is there, ICP is monitoring is indicated, but invasive ICP monitoring nowadays not recommended because of bleeding risks. Then ALF characterizes a hyperdynamic state of cardiac failure, low arterial pressure because of there is a low SBR, nitric oxide production is increased on the CGMP mechanism. So fluid resuscitation is the first line, and use vasopressor you can be used if MAP is not adequately maintained. And treating respiratory failure in ALF, always keep low PEEP, otherwise there will be venous congestion because it decreases the venous return. And hepatocyte necrosis causes the hypoglycemia because it prevents the gluconeogenesis, and also is glycogen storage has been defected. So so acute liver failure, there are other area you have to understand that what is the commonest cause. If they said the commonest cause in the Western country, it is due to acetaminophen poisoning, and but in Asia, if the question is given in the Asia, then it is a hepatitis is the main cause for acute liver failure, then the paracetamol. So there will be a twist in this the commonest cause, and also other toxin causing the mushroom can also causing the hepatic failure. And among the viral hepatitis, hepatitis B is highest, then hepatitis E. Sorry, hepatitis A is the highest, then B, and then E. And sometime acute liver failure can be happen due to shock liver and Wood Cherry syndrome, other causes of acute hepatic failure in the Wilson disease, and your HELLP syndrome in pregnancy. So the etiology specific acetaminophen toxicity is the highest in Western country. So then you have to remember the criteria for a diagnosis your acute hepatic failure. So what is the criteria? Can anybody can utter these things? What is the criteria to diagnose acute renal failure? So acute
Acute
hepatic,
liver failure, King's College criteria can be
yes.
taken with bilirubin of more than 300 millimoles of hepatic encephalopathy grade 3 and 4, and prothrombin time more than 100 seconds, or INR more than 6.5, plus yes.
So yeah, it's very good. And hepatic acute hepatic failure, how you will classify it is whether it is a hyperacute, acute.
Hyperacute, acute, and subacute.
Yeah. So the basis of
On the basis of less than 7 days hyperacute, 7 to 28 days acute, and more than 7 to 28 days subacute.
very good. So now next coming to your general consideration, the CT scan of brain you have to do to rule out any hemorrhage, and second the brain edema. Okay. And you have to know the management of acute hepatic failure for acetaminophen poisoning. So what is the antidote for acetaminophen poisoning?
N-acetylcysteine.
N-acetylcysteine. Anybody can tell me how it's work?
So
N-acetylcysteine
it
replenishes the
replenishes the
glutathione storage.
glutathione.
Glutathione storage. It replaces the glutathione storage for and this glutathione is help to
Like
metabolize
NAPQ.
active metabolism of the paracetamol. What is the name of active metabolite? Just you utter the
NAPQI.
MAPQI, yes. Full name?
N-acetyl para-aminoben.
Anyway. So now the question might come regarding the King's College criteria for liver transplantation. So anybody can tell me the criteria for liver transplantation? So when there is a fulminant hepatic failure, there is a King's College criteria. Basically acetaminophen induced disease or non-acetaminophen induced disease like your hepatitis. So acetaminophen induced disease when there is a pH is less than 7.30 or prothrombin time is more than 100 seconds or your creatinine is more than 3.4 and grade 3 or grade 4 encephalopathy. But nowadays it has been taken instead of prothrombin time, they are taking that your INR. So if INR is more than 3.5 or more persistent more than 4 and pH is less than 7.30 or you have a grade 3 or grade 4 encephalopathy, then if it is a case of acetaminophen poisoning, then you have to think about your hepatic transplant. In non-acetaminophen induced disease, again, the prothrombin time is more than 10 seconds or the age is less than 10 or more than 40. And then you have a etiology of non-A or non-B hepatitis or duration of the jaundice before onset encephalopathy more than 7 days. Then these are the criteria, bilirubin more than 18. These are the criteria for your liver transplant. So for liver transplant, King's College criteria, you have to